Thank you. It's an honor to be here, to be on a panel with Cindy, who was the head of DMHC back under the governor's administration. Coming in a panel after Norm Ornstein is a challenge. I actually advised him against that joke about Stormy Daniels. I can't keep up in any way, shape, or fashion. But thanks to Margaret for continuing this conference, and I think it's one of the best run I've ever experienced, and I'm delighted to be here a second year. Wendell introduced Covered California this morning as the model for what can happen when you really embrace the Affordable Care Act and implement all parts of it. And I think that that's true, and I'm just delighted to be here to represent that work and under the leadership of Peter Lee, who is, I think, a giant in our times. He's just done a terrific job. I didn't frame the slides in terms of predictions or forecasts, so let me just start with that. That I'll then try to document, and then I'll add a third question at the end that hopefully will stimulate some thought. But first is that in partnership with Medi-Cal, that the Affordable Care Act is stable and strong in its implementation in California, and that's particularly true. I can speak for the exchange, but it's really established in the marketplace here in California. Second, that we have a dual mandate. One is expanding coverage, which is what we talk about the most, but we're the only exchange with a chief medical officer across the country. And the body of work that I'm involved in has to do with quality, as Cindy mentioned. And I think in particular, my prediction is that variation in performance among our providers is going down. And that's partly due to our work together with a lot of partners, particularly other purchasers, because variation, which we measure at the provider level, starts with us as purchasers. If every purchaser looks at their data and says, we're special and different, and therefore this is our priority, and it differs from the other purchasers who say this is their priority, that drives the delivery system crazy. There's no way they can address all those different priorities. So by working together with DHCS on Medi-Cal, with CalPERS in particular, and also with the Pacific Business Group on Health, where both Peter and I came from, we can align the requirements for more than half of California. And that gives us a chance to say these areas of variation are really important to us, and we see that going down. Second, I think integration and coordination of care are winning in their battle with fragmentation. The state is huge, but we have a big opportunity to bring folks together to work together. So that's what I hope to document over the next few slides, and then look forward to the discussion. Just real quickly, the record in terms of coverage is pretty remarkable. We've dropped our uninsured rate from 17% to now under 7%. And it's about half of those are undocumented and therefore not eligible for under the current law. So the real uninsured rate is 3.6%, which is at least of the eligible population. That's huge. And this is a slide showing our niche in the market. The employer-based insured population is stable. Now, that's not what the prediction was at first. I think some of the uncertainties, the opposition has been part of why some employers that might otherwise have decided to move to a defined contribution, and as was discussed this morning, and made it possible for employees to get coverage through exchanges, that didn't look predictably secure. So I think that's part of why that hasn't happened, but it's only part of it. I think it's also a major source of loyalty for employers that's really knit into the fabric of American culture, and I think that's not going away, and that 18.2 million in employer-based coverage is stable for a long time. So the individual market is divided in two parts: those who get their coverage through the exchange, who 85 to 90% of whom get subsidies, and those who buy directly. And then there's a small part of the people who buy directly who get non-mirrored grandfathered product. But the vast majority of the 2.4 million individual market are our products, either on the exchange or off. We have a broad range. We have 11 health plans that have been with us since the beginning. They cover the entire state, and almost every county has at least two offerings for people to choose from, so there's a competitive market. And in the major metropolitan areas, we have 6 or 7 choices in LA as an example. And we actually turn down applications if we don't think that a new plan offers enough differentiation or something different there. I wanted to discuss at least some of the key ingredients. These slides are available on that app that you can get from outside, so the reference that I'm going to be speaking to is available for a more detailed discussion if you want it. But I wanted to discuss a couple things. One is the benefit structure to meet consumer expectations. If you read Sarah Cliff's discussion of her interviews in Eastern Kentucky, of why there was so much upset at the implementation of the Affordable Care Act and what they thought they were voting for in terms of improving it, what they were really talking about is deductibles. And the fact that they often, because of the need to meet deductibles, didn't feel like they were getting insurance. And I think maybe others, we've got someone from Arkansas here who can help with that. But the way Covering California built our benefit designs, and they are standard for all plans, is that we excluded ambulatory care from the deductible, which means that people can have to make a copay to see their doctor, either primary care or specialty care. And even in bronze, they get their annual free visit for preventive care and 3 other visits to ambulatory care. And if you need more than that, you shouldn't be signing up for bronze. People feel some value. They're able to get care under insurance right from the get-go. So I think that's been a huge part of the success for Covered California. A second is the marketing and outreach. Our budget is $115 to $120 million per year that we manage on behalf of the plans, so that we can market to all ethnic groups and all regions of the state. And that's bigger than the original budget that the administration cut by 90% for 35 states under the federal exchange. The result of that has been that we do have healthy people in the exchange. Our risk mix, which is what's over 2 years, the 2 different colors are 2015 and 2016. The federal market, the risk mix was 1.69. We're at 1.35 on average. That's a big difference. And it means that we've been able, until this year, to control prices quite a bit. And all of our plans are profitable. So it's a good place to do business, and the plans compete on the for the population, and they're successful. So those are just two of the things, and I would encourage you to get the full paper because it's worth reading. But there are plans that haven't joined or who joined briefly and left. And so there was some discussion this morning about maybe having exchanges coming back, perhaps, for the rest of the commercial market. Our exchange has 5 characteristics that are standard that make it a truly competitive experience that I think are really critical, that are different than what we've experienced before. Guaranteed issue, which has gotten a lot of press, community rating, risk adjustment so that it's not dangerous to compete for sick people, essential health benefits, which is just critical, and then what I described before, standard benefit design so that HMOs and PPOs have the same benefits. And then what's variable is the price to market, the network design, the quality of care, the service provided, and the philosophy of care. So that's what you want competition on, right? And the other stuff is standardized. So we're working now to really define what makes the difference between the plans on the left and those on the right who have not participated. And there are big names there that are successful in other markets that aren't quite so level. Maybe that's something we could discuss later. We don't yet have conclusions about that, but I'd be interested in your reaction. So there's been a couple references to how Cover California managed the fact that the cost share reduction reimbursement went away. And I'll just, for those of you who don't spend all your time in the exchange, a really brief discussion of this in the time I've got. There are 4 silver plans. The second lowest silver of the 70% AV is what sets the premium subsidy. So that's the basis. When all the other silver plans, which are for the lowest level of income, reduce the cost share that folks have to pay, the plans have to implement those variations at their expense, and the cost share reduction was a reimbursement for what the plans were giving up in the co-pays, the cost share from the patients. So it wasn't any kind of a scheme or anything that was a subsidy to the health plans. They were obligated to implement it that way, and it was a real expense they were being reimbursed for, even Stephen. When they went away, because it only applies to silver, what we decided to do was to load the entire burden that would come from on the silver plan. So that also meant that the premium subsidy went up. And someone predicted that would result in more gold, and I'll show you in a minute that that's actually what happened. The other thing that we did, because that's not fair to the people who don't get subsidy, is we created a near silver plan for the health plans to market off exchange. And so we made the co-insurance or the co-pay for an ambulance $5 more expensive. And otherwise the plan's the same. And that was marketed off the exchange, and we think we didn't quite hit the open enrollment that we might have, or the renewals, I mean, that we might have, and we think, we don't have the numbers yet, but we think a lot of the folks went to that near silver off exchange, but it's still part of the risk pool in the individual market. But here's what happened. This is this current year versus last year, and you'll see that at the lower income levels, the proportion of bronze and silver stayed the same, but as the income level went up, the proportion of gold at the top there rose from 4% to 13%, and at the highest level to 15%, and it all came out of silver. So that's, and they basically got, compared to the prior year, they paid about the same as they would have because the subsidy had gone up, and they got a gold instead of a silver plan. So that's if there's any effort, I'm looking at you, Wendell, to go back to providing the subsidies, this would really confuse our consumers if that were to happen. It clearly was not a good idea for the federal budget to do this, but now that it's happened, it actually would be kind of awkward to go back. So last thing about globally, and this is about quality, and I just want to say, this is, you can see this in your, if you get it on the slides, but I wanted to point out that over time, the quality as measured by HEDIS and CAPS is going up. So 2015 data as reported in 2016, so 2015 was our first full year. We first marketed in 2014. We didn't really finish. Most people had 6 months or less coverage that first year. So the first full year was 2015, and in that year, 8 plans had 2 stars or less when you aggregate everything about HEDIS and CAPS. But last year, when we reported on 2016, so there's always a lag, 8 plans had 3 stars or better. Now, most of that came from 2-star plans moving up to 3-star, but that kind of a broad-based across 11 plan improvement is basically just a testament to the fact that coverage matters. That people who hadn't previously had insurance are now getting care, and so they're learning how to use it, so their satisfaction goes up because they're feeling competent in the system, and their clinical data improves because they're getting care and they figured out how to take care of their diabetes. So this is really exciting. I think it's a huge demonstration of what's possible. But we're going beyond that. That's just care as it was to try to improve care. And I've got about 7 minutes left, I think, to describe all really what's my job. And that is, we're really promoting new models of care like the medical home and ACOs. All of our enrollees now have a primary care physician, including all PPO members. That's, I think, first in the country. I don't think that's happened anywhere before. We're not asking, in fact, we're not encouraging at all that be a gatekeeper. I'm a family doc, and I certainly didn't include in my application for medical school my burning desire to be a gatekeeper. But primary care should be the first point of contact and advocate, and so now that they're connected, we're trying to do more. We're also insisting, and the fourth one down, that health plans bring us quality networks. And that means addressing variation in practice. HEDIS addresses average, right? It's the average number across. But if you look across, I'm going to skip that. all care. In fact, there's huge variation underneath that average. And this is just one area. This is the low-risk cesarean section rate by the 240 some hospitals that deliver babies in the state. The national target is 23.9%, which is not an aggressive target. The range in California is from 11 to 77%. 3/4 of women coming to some hospitals in our state are having a primary C-section for a low-risk delivery. When I talk about reducing variation, I mean that the right side of the curve will flatten. And we believe that will happen because we're insisting that outlier poor performance be removed from our networks by the end of 2019. And in that, we're being joined, not in that requirement, but in the same target by DHCS and CalPERS and PBGH. And so all the purchases are aligned in saying this is important. So 40% of our hospitals have already achieved it. 40% are in a coaching program with the CMQCC, which is a collaborative working on Medicare, on maternity. And the other 20% are having visits from network contractors who work for health plans in Covered California being told, either you get together, start working on this, or we can't contract with you because Covered California doesn't want you in our network. So that I think documents why my prediction that we'll have less variation might work. You can get a similar curve, really the same shape, sine curve for any hospital safety measure. And we're working with Partnership for Patients in the same way we're working with CMQCC and making the same statement. So all the avoidable complications like central line infections or urinary tract infections meet the same kind of curve, and we're addressing that variation as well. So we have the attention of the hospitals in the state. Primary care is a major focus. I'm primary care doc. Peter Lee's father was head of the family medicine department at USC. We believe the data that if you build a system on primary care, it will be more cost-effective and higher quality. We started with the benefit design I described that excludes ambulatory care from the deductible. Now every enrollee has a primary care doc. We're requiring implementation of something that looks like at least the CPC Plus model that was described earlier this morning that adds some kind of population-based care management fee and a quality performance bonus to fee-for-service. And we're asking all the plans to move toward supporting their primary care docs and getting recognized as a medical home. So, I think I've documented that with the Medi-Cal program that the Affordable Care Act is alive and well in California, that we're doing some pretty cool stuff, that there's good reason to hope that fragmentation is over or at least fading, and that integration and coordination is proving itself. The purchases are helping drive priority improvements across the state. And finally, the open question that I have is we've now got a natural experiment occurring between states like California and those who haven't expanded Medicaid or haven't implemented the individual market with the enthusiasm we have in California. So the big question is, will the nation learn from that? One example that gives me hope is that in states like California, where we've really gotten folks coverage, the employers are experiencing lower cost inflation, and they have a lot of influence with state legislatures. So if we can really document that it's true that that employers are doing well because of the Affordable Care Act, then I think we have hope that other states will follow our example. So with that, just a very quick, the closest I get to telling jokes. Michael Pollan has long told us, and he's from Berkeley, where I live, Berkeley, that you should eat food, not too much, and mostly plants. And Kevin Grumbach, who heads up the UCSF Family Medicine program, tells us we should get medical care, not too much, and mostly primary care.